Welcome everyone to the 5th annual NORSE Fires Scientific Symposium. We're very excited this year to present the symposium, which is named the Early Recognition, Treatment, and Communication of NORSE and Fires. And I think the concept that we want to present today is the concept of early. And I guess by early, I mean early recognition, early treatment, and the importance of early communication with the families. And we really believe that identifying this early, treating early, and communicating early will improve outcomes and families' experiences. So we're very excited to put this together. So some housekeeping information, we will put the attendance on muted during the lecture. We will have time after each talk for some question and answers, and people can do this by the chat. So or raise your hands, and then you'll get unmuted, and then we would ask you to introduce yourself, and your affiliation, and then go from there. We are recording this, and so we would hope that everybody would be polite and respectful in their verbal and written comments. And we will have, as I said, we will have some time after each session for question and answers, and we have some time for question and answers at the end of this. So I just want to, I just want to show you one slide. And this is the one slide that I think kind of emphasizes what I said about early recognition and treatment. And this comes from a FIRES workshop that grew out of the American Epilepsy Society a number of years ago, probably started about 8 or 9 years ago. But basically in this, we have timelines in this for the workup, for the presentation, and for the recommended treatments. And again, the fact that we have put this together in days of what should be done day 1, day 2, days 3 to 6, emphasizes the fact that it's early recognition, early treatment, and early communication will help to improve the patient outcomes. Now, let me stop sharing here. Okay. I'm not going to introduce each individual speaker now, just for the sake of time. The speakers are all experts in their fields, of course, and have spent a good deal of time devoting their attention and their careers to the treatment of NORSE and fires. And we will ask each one of them to introduce themselves at the beginning of their talks. And so I think it's time to move on to the first talk, which will be on the recognition of NORSE and fires. So Ronnie?
Absolutely. Can you hear me?
Yes.
Can you also see my screen?
Yes.
Fantastic. So thank you very much, Jim, and thanks for the opportunity to start off and talk about the clinical course and diagnosing NORSE and fires. So these are my disclosures, none that are really relevant. And these are the objectives that I want to talk about. So I want to go back a little bit and talk about the definitions of NORSE and fires. So this is something that most people on this call probably know, but has some implications for diagnosis that are important. And then we'll go through the clinical picture a little bit, and then also I'll discuss a little bit about the pathophysiological mechanisms, in the sense that that's part of the important part of why early diagnosis is so important. And then I'll go through a little bit concerning the diagnostic workup and strategies and things. So first of all, this is evident to most everyone on here, but it's important when we're talking about diagnosis to just acknowledge that NORSE is not a diagnosis. It's an umbrella term of different diagnoses, also excluding other diagnoses. And this is the same is true for fires. So And this has implications, as we'll see. Also concerning the cryptogenic group, so cryptogenic, NORSE cryptogenic being a term that's retired by the LAE when it comes to epilepsy, but it's still retained in this context. And this is the group where there is no etiology defined or found even after an extensive workup. And this is an interesting group. We'll come back to this many times today over this seminar, probably, in the sense also that it has important implications for treatment choices. So if we look at the clinical presentation, what are NORSE and FIRES cases? So these are patients that are previously healthy. By definition, there's no real family history or patient history indicating that they're susceptible to status epilepticus, and yet they end up that way. And they may or may not have a prodromal phase of an infection, usually maybe different kinds of infections, but involving fever that may or may not be resolved at the time of status epilepticus. There's often a short interval, it doesn't have to be, but there's often a short interval of fever. And there's often also a tendency or an element of encephalopathy at the onset of, or preceding the onset of the seizure situation. And then when the onset, when patient may either go into status epilepticus right away, or there may be a gradual increase of recurrent seizures that evolves over hours or days into a prolonged status epilepticus. So the semiology of this in the status may differ widely, but if they do go into refractory status epilepticus, it's very common. In most cases, actually, also then go into super refractoriness, as defined as being refractory also to anesthesia. And the outcome, as we'll hear more about later, is still fairly grim, with high mortality, up to 30%, a little bit more in adults than in children. And in survivors, quite a lot of sequelae, both when it comes to seizures and drug-resistant epilepsy, and also cognitively. And this was summarized in this systematic review a couple of years ago by Olga Tarashenko's group. So when it comes to diagnosing or diagnosis in NORSE and FIRES, there are some challenges. One is, of course, that it's very rare. NORSE is, and it's maybe not as rare as what we're seeing, because it's an under-recognized condition, but it's also problematic that it's so hyper-acute, which makes diagnosis very urgent and difficult. It's also diagnosis of exclusion, not being a diagnosis in itself, which also presents the problem when have you excluded enough, so to speak. And then we'll talk more later about biomarkers. We're still lacking a biomarker to really identify these patients. And then also, of course, we know that correctly identifying the etiology makes a huge difference. It's very important when it comes to choosing how to treat these patients. And we want to treat these patients early, right? So, whoops. Now everything went away. That's very strange. This is supposed to be much more on this slide. See if I can, we'll go there instead. So if we look at etiologies for NORSE, we know that this differs a little bit in adults and children. And one of these things that differs is if we look at children, and this is from Nicholas Gaspard's paper some years ago, that there's quite a large proportion of cases that are autoimmune, either in paraneoplastic or high-risk antibodies or membrane-bound antibodies, whereas this group is much, much smaller in children. And we know that the development and the discovery of different antibodies that are related to epilepsies and also status epilepticus and refractory status epilepticus has really grown over the last decades, both concerning again, the paraneoplastic antibodies and the ones that are membrane bound. And I put little rings around this, the ones that are more prone to give rise to seizures and also to status epilepticus and refractory cases. The other thing that can be shown or seen on this one is that the fact that we have a lot of cryptogenic cases, and this is true both for adults and children, and more so in children. So more than half in most studies end up being cryptogenic even after a thorough workup. And this number can be going up to 80 or 90% in different studies in children. So one question then is, of course, have they undergone what is an adequate workup? And Simona Lattanzi and Eugen Trinka's group they performed a systematic review looking at the etiologies a couple of years ago, and they went through almost 200 studies looking at what kind of workup did the patients have. And what they could see was that not everyone, of course, had a complete workup, but in many cases, the workup was pretty far from complete. So, for instance, they could see that autoimmune antibody testing was running only 60% and genetic testing in below 20%. And in this systematic review, around 70% were considered cryptogenic. One way of trying to increase an early recognition is when a couple of years ago, one of the Japanese groups introduced a cryptogenic NORSE score. So this is a score, predictive score, trying to predict whether a NORSE case will end up being cryptogenic or not early in the status epilepticus. And as you can see, there are 6 variables here. One is high refractoriness to seizure medications. Then being a previously healthy individual and presence of fever prodromal. So these would be the FIRES cases. And then there are 2 variables after that, the absence of behavioral or memory alterations and absence of orofacial limb dyskinesia. So these are basically indicative of autoimmune encephalitis. We know that already. And then there's symmetric brain abnormalities. And using these 6 variables and having a cutoff at 5, so scoring 5 or 6 points on this in this algorithm gave a specificity of 100% and a sensitivity of 94% in this seminal paper. But there was only 11 patients in this group, so it needed to be validated. And it actually was a validation that came out just a couple of months ago, the first validation of this score. So this was a Brazilian study where they have both pediatric and adult patients. You can see that the pediatric patients were more had a more tendency of being FIRES cases, and also a higher proportion of NORSE cases. But you can also see that the NORSE score was a lower, they did not identify all the cryptogenic cases. And looking at this here, they again found 100% specificity using the same cutoff of 5. So all the patients that were identified early as probable CNORSE patients actually turned out to be CNORSE patients, but they actually also missed quite a lot. So the specificity or the sensitivity was below 60%. So it's important to notice also that this cohort came out of the Brazilian Autoimmune Encephalitis Network. So this was a selected patient, and the scoring system needs further validation. I'm not going to go into pathophysiological mechanisms so much. There will be other people talking about that more, but I just want to point to a couple of studies that indicate something important, namely that in the last couple of years, a couple of studies have indicated that cryptogenic NORSE cases differ pathophysiologically from other cases. In this study that came out of China, they looked at autoimmune cases, in this case, NMDA, NORSE cases, and cryptogenic cases, and could show that the protein profiles were completely different, pointing to the cryptogenic cases being more involving the innate immune system than the adaptive system. And the group of Larry and Aureliana also at basically the same time show that the same thing with pointing at innate immunity being involved, and also showing the importance of the systemic response there. Aurelia has also published this paper recently where they've used cytokine profiling to try to cluster patients. And again, they can see that there is a cluster pointing to having more involvement of the innate immune system, and another cluster which involves autoimmune process. And this, of course, has huge implications for the choice of treatment in the end. And this is the important thing, and this is what I want to sort of point out when it comes to diagnosis, and why this is so important is to remember that when we're talking about immune responses that may be of importance in NORSE and FIRES cases, we have 2 different sides where the innate immunity is one, and this is driven by glial cells and the production of pro-inflammatory cytokines that will lead to seizures and refractory status epilepticus, and that this is different from the adaptive immunity, where an influx of immune cells will lead to many things, but including also production of antibodies. And this will of course have implications for choice of treatment. And the cryptogenic cases appear to be, the problem appear to be in the innate immunity. So a couple of years ago, when we published the papers on the consensus paper on workup, there was an inclusion of a suggestion for diagnostic workup, one that was a standard workup and one that was more in selected cases here. And I want to point to some of the things that are possibly important here. One is that in all acute management, including diagnosis of NORSE and fires, this should be performed by a multidisciplinary team, including things that are important for diagnosis. That would be immunology or rheumatology and infectious disease, and also that you have access to continuous EEG in this care. The early testing for autoimmune antibodies, of course, is important. And when it comes to both the investigations in serum and CSF, I'll show you a paper a little bit later with suggestions on actually what to do there. This involves rheumatological or immunologic evaluation as well as infectious, so indicating again the need for having different specialists on board on this endeavor. Of course, the importance of early MRI, as being during the first 48 hours, including contrast enhancement, but also remembering that in many cases there will be an MR negativity in the first MRI, so indicating the need and the importance of having repeat MRIs performed. Also, spectroscopy and PET can be useful. When it comes to genetic case testing, this, as we saw, wasn't done in many cases in the systematic review, but it should be remembered, and probably in a majority of the cryptogenic cases, and absolutely in children and in small children, this should be performed. And we know that the genetic yield, as far as these monogenetic findings, is very, very low in NORSE and especially in fires, but we do find cases. And this quite busy slide here indicating a case report that came from Eugen Trinka's group a couple of years ago emphasizes this. This is a 14-year-old boy that had his first episode of NORSE when he was 14 years, which then resolved, and he was off medications even at 16 years. And then he relapsed at 21 years with a second episode of superrefractory status epilepticus. At this time, he had genetic workup, and it turned out to be a homozygous deletion in the FASKD2, so a mitochondrial disease. And then, of course, I mentioned the CEG monitoring and also brain biopsy. We'll hear more about cytokines later, but we do usually look at them, and they may be useful as biomarkers, both for identifying the pathology and also the disease progression and response, but we don't really know how to use them stably yet. And then malignancy screening should not be forgotten, of course. So the last slide before I just sum this up is I want to point to this paper that was published by Subida Sheikh and Larry Hirsch 2 years ago, where they really nicely described a workup and diagnostic workup, including this algorithm. And on the left-hand side, you can see a slide. There's actually 3 pages of different suggested workup or diagnostics that could be considered in diagnosing. So in conclusion, we know that it's important with the early recognition and early diagnosis is needed to adequately choose what kind of treatment would be appropriate for that person. And we know that will have positive long-term effects, of course. It's also important from a prognostication perspective and involving the family in decision-making and communication. So the thing to remember is that we always say that time is brain. This is true also here because we know that the early diagnosis will enable the correct early and aggressive treatment. In all cases of refractory status epilepticus, particularly NORSE and in particularly cryptogenic cases, we should, of course, consider the immunological perspective, the need for multidisciplinary care, the need of having continuous EEG monitoring, and remembering that early immunotherapy, even before diagnosis, final diagnosis is set, may be very, very important. So there are some research sources available online. This is organized today by the NORSE Institute, and here's collated a lot of different material, including recent publications. And then there's the monthly case seminars where we discuss tricky cases that's possible to access. So with that, I'll stop, and I'll be happy to take any questions.
All right, thank you, Ronnie. I'm looking in the chat room. For now, I don't see any questions specifically related to your talk in the chat room. Do we have questions from the audience?
Maybe I'll just make a comment while waiting. That's all right.
Certainly.
See if there's other questions show up. I just point out that as we screen patients more prospectively, we're noticing a lot more of two things. One is milder cases. People always think about this when they're really prolonged super refractory, but we do see milder cases now as prospectively. And the other is older patients. We're seeing a lot more older adults who really have classic NORSE or fires. I think in the past, nobody thought about that in older patients. So some of the fact that NORSE and fires are really in young people may just be because nobody thought of it. So I think it's really an underdiagnosis issue still. And it's yet to be determined if what we're seeing in older people is the same or different. There's some evidence that it's different and there's less inflammation, but I think we need to study that.
Hmm.
I can't see all the outside speakers. Can someone see all of them? But I don't see any hands raised at this
Yeah,
point.
yeah, we don't have any
Okay.
hands raised, or I think folks can unmute also if they have a question.
All right. I don't see any hands. Oh, I'm sorry. Suki Ko makes a comment, not really a question, that recognition of NORSE and fires as involving innate immunity is going to be an important therapeutic implication. And of course, that's a correct statement, and we will address some of that in the talk that will be under the promising immunotherapies. I think it is interesting that for years and years regarding fires and NORSE that we presumed, or the presumption was that there was a defect in innate immunity. And that is turning out to be the case with a lot of the research that is being done. So I think we can move on now to the next talk. The next talk.
We do have a hand raised now.
Oh, okay.
Hi, good morning. I'm Maite here from Mount Sinai. I have a question. Maybe it could be too early for this question. First of all, for the diagnosis, can we consider the definition of NORSE on a patient that already has a persistent genetic mutation? That's number one. Like we have a baby here that has been since the NICU 17 months here, but he started to have super refractory status epilepticus when he was 16 months, and we discovered that he has a genetic mutation that is called MPK2A1. I'm going to send it on the chat. And so he had a few seizures here and there, but that was okay. But suddenly he has this refractory bilateral frontotemporal that we have to use Versed, ketamine. We have to put a VNS, 5 anti-seizure medications. Now he's better. We are trying to decrease. So can we apply the definition of NORSE in this case? And the other question is that if this mutation that is MPK2A1, can we use an MEK inhibitor like is used for patients with neurofibromatosis? And neurofibromatosis is more for like the overgrowth of the tumors, but it is something, or do we have to treat it with any other like anti-inflammatory medications like IVIG, steroids in this case? So that's kind of the question.
Right, thanks. Yeah, so absolutely. I mean, in this case, this is a very young child, obviously, but fulfilling NORSE criteria, basically. But I think you're pointing to something important, namely that we're this is an umbrella term, and there's reason to believe, of course, that there will be heterogeneity within this group. So if you have the mutation that you find early like this, and maybe an epilepsy that just starts with a refractory status case, all that was what I was saying now about the immune system being involved as a driver may not be true in those cases, and that you need, of course, to include in your evaluation of what kind of treatment. On the other hand, I think that in most cases where you have a refractory status epilepticus, the immune system will be activated. So even if that's not the driver or the cause of it, you will have immune effects in the end. Now, I'm not, I don't know exactly about this mutation and the use of MEK inhibitors. So, but that's, I mean, once you have a diagnosis like this, of course, you need to try to individualize the treatment rather than treat it as a general NORSE patient, basically.
I believe we have to move on at this point. Thank you. So the next talk will be on the biomarkers for NORSE and FIRES, and we'll start with Raquel.
Hi, good morning. Can you see my screen?
Yes.
Wonderful. 1 second. Thank you very much for the opportunity to present to you this morning. My name is Raquel Ferris-Muller. I'm an associate professor of neurology and pediatrics at the Medical College of Wisconsin, and I'm going to be speaking about EEG and MRI features heralding cryptogenic NORSE and FIRES. I have no disclosures, and my objectives for this talk are to review MRI and EEG findings that are reported early in cryptogenic NORSE and FIRES. So it's very important to highlight that seizure refractoriness leads to more seizure refractoriness. In this figure, we see a potential hypothesis of this interplay, where after a febrile illness, there is an activated innate immune system which provokes a release of cytokines and other inflammatory signals, opens the blood-brain barrier, and then which, after that, through various mechanisms, influence different receptor trafficking changes that will lead to orientation of the seizure compass towards a pro-excitatory state, which leads to more seizures, which in turn causes this mechanism to be self-sustained in sort of a vicious cycle. So understanding this concept is very important because by the time NORSE is identified, when the refractory status epilepticus is well established, these changes may have already been perceived by the central nervous system milieu, and seizure refractoriness may be far too advanced and established. So with this in mind, it's important to ask, when did NORSE start? Did it start when the patient ceased through their second continuous infusion, when they ceased through their second-line anti-seizure medicine, when they ceased through their benzodiazepine rescue? What about when they presented to the emergency department with their inaugural seizure? Or did it start when they were home and were a little bit encephalopathic? And why is it so important to recognize NORSE early? Ronnie already alluded to this, but just to emphasize the points, halting the seizure refractoriness cycle early on may prevent more seizure refractoriness. Early recognition may lead to initiation of targeted therapies earlier. Early targeted therapy initiation may lead to better outcomes, and early recognition may also allow for prompter enrollment in research to study potential medication choices that may really change outcomes. And lastly, and very importantly, it is crucial to communicate clearly with families who are undergoing this scenario. I'm going to talk about two diagnostic tools that are almost invariably used early in the course of NORSE and FIRES, and they are continuous EEG as well as MRI. So first, let's talk about some MRI findings. As Ronnie already mentioned, the most common MRI finding early in patients who have NORSE and FIRES is a normal initial MRI. However, there are also reports of some MRI abnormalities that are relatively non-specific, but they've been described in cryptogenic NORSE series, especially when they are preceded by a fever, i.e. FIRES. So in this image, we see 4 patients who have the claustrum sign. The investigators of this study performed a retrospective analysis of 31 patients, 28 of whom had FIRES. All patients showed the T2 flare hyperintense foci in the bilateral claustrum, appearing on average 10 days after status epilepticus onset. The claustrum sign coexisted with other areas impacted, such as the mesial temporal lobe, the pulvinar of the thalamus, as well as the insular cortex. These findings have been replicated in other reports, and as Ronnie just demonstrated earlier in this study, investigators were trying to develop a clinically based score that predicted cryptogenic NORSE early, and the last point of the score was the presence of symmetric T2 abnormalities, and within these are included the claustrum sign as well as other location of T2 hyperintensities. As you can see from this figure of 4 patients, MRI of the brain shows symmetric increased DWI or flare signals in the amygdala, hippocampi, fimbria, claustrum, insula, and frontotemporal cortex. Lastly, one imaging modality that deserves a little bit more study is blood-brain barrier imaging on MRI. As I had mentioned earlier, one of the factors that occurs after innate immune activation is blood-brain barrier opening. In this study, the investigators wished to characterize the blood-brain barrier dysfunctions using dynamic contrast-enhanced MRI in patients who had NORSE. They included patients who had NORSE, patients who had encephalitis that did not have status epilepticus, as well as healthy controls, and then they compared the groups and measured K-trans permeability in the hippocampus, basal ganglia, thalamus, claustrum, periventricular white matter, and cerebellum. And then they compared the groups. Of the 7 NORSE patients that they included, it's important to mention that 6 of them had cryptogenic NORSE. The investigators noted that patients who had NORSE had significantly increased K-trans values in the hippocampi, basal ganglia, and thalamus when compared to healthy patients. And they also noted that they had increased values in the thalamus and basal ganglia when compared to encephalitis patients who did not have status epilepticus. So blood-brain barrier imaging may prove to be a useful tool for early recognition of cryptogenic NORSE. Switching gears a little bit, let's talk about some reported EEG findings. So first of all, why is EEG a great biomarker for cryptogenic NORSE and fires? Well, it is used often, it is used early, it is used serially and longitudinally, and it can be analyzed with machine learning. Over the next few slides, I will focus mostly on fires cases, as those are some of the cases that have the most examples of abnormal EEG findings that fit under the umbrella of cryptogenic NORSE. So in 2017, a group of investigators from Children's National Medical Center described early EEG features in 7 patients who had fires. The investigators reviewed EEGs in 2 segments, the initial 12 hours of the recording and the 12 hours prior to the initiation of a medically induced burst suppression coma. They noted several findings. First, a beta delta complex that resembled extreme delta brush in all of their patients in at least one of the EEGs. They also noted a staccato type of seizures in 6 out of the 7 patients, an alpha lead-in to the seizures in 6 out of the 7 patients, as well as shifting laterality in 4 out of the 7 patients. These findings, while non-specific, have been replicated in other publications. So just to illustrate what I'm talking about, this is an example of 4 patients from the CNMC series who had the beta delta complexes that looked like extreme delta brush. These findings were noted in a series from Beijing, which included 26 children. And in this series, they noted this finding in 15% of their cohort. This is an example of the focal fast activity that preceded the clear spike or spike wave complexes. And this was seen in 6 of the 7 patients from the Children's National Medical Center series. And in the retrospective series from Beijing, these findings were seen in all of the other patients. In this example, we see shifting ictal activity noted in a bipolar montage. And this is another example of shifting ictal activity that was reported in a different study. So as you can see, detection of these EEG findings may serve as key towards earlier detection because if anything, these patients are usually connected to a continuous EEG monitoring. So what about future studies that pertain to EEG? I'm excited to share that a group of investigators are looking at early quantitative EEG stigmata of cryptogenic NORSE and fires and are looking to study features such as extreme delta brush, as you can see on the left side of the screen, macroperiodic oscillations, the alpha lead-in, as you can see displayed here, to the seizures, ictal shifting activity, and the crescendo type of seizure burden. In conclusion, recognizing heralding signs of cryptogenic NORSE and fires is of paramount importance. MRI and EEG play a key role because they are performed commonly, early, serially, and can be analyzed with other tools such as machine learning. And blood-brain barrier imaging as well as quantitative EEG techniques are currently being studied in their role of predicting who is going to have cryptogenic NORSE. Thank you so much.
Thank you, Raquel.
take
We're going to
questions.
move on to have Yi-Chen Lai give his talk, and then we'll have questions at the end.
I thank you very much for the invitation and to be part of today's NORSE Symposium. I'm Yi-Chen Lai. I'm one of the pediatric critical care physicians who has a long-standing interest in NORSE and fires pretty much since my fellowship training. And so for the next few minutes, I'm going to briefly go over some of the potential markers for NORSE and fires. The take-home message, unfortunately, let me see if I can move my slides, is that right now, there is still not a diagnostic test that has emerged as to either confirm or exclude the diagnosis of NORSE or fires, but there are several potential candidates that may be helpful in terms of patient clusterings and outcome association and predictions. Now, the study that I'm going to show you today is all from serum biomarkers because the data from the serum studies are a little bit more robust as compared to the CSF studies. And also from the practical sort of standpoint, it's much easier to sort of order a blood test than trying to sort of subject the patient through serial spinal tap. And I'm going to sort of briefly mention the clinical score that Ronnie already has mentioned. It actually turns out that, you know, despite the fact that we have a lot of fancy tools and a lot of advanced diagnostics, a lot of times, you know, your history and physical, as we were taught in medical school, still remains one of the important aspects of diagnosis. Now, as we heard so far, that aberrant immune regulation is thought to represent a major pathological mechanism for NORSE and fires. And so there has been a very long-standing interest of using cytokines as a potential diagnostic tool. And here's one of the study back in 2019 in a group of children with fires. And as you can see, compared to the control subject, the children with fires has elevated cytokine levels on pretty much every single one of them that were measured. However, when they compared the children with fires, none of these cytokines seems to be able to distinguish fires cases from other neurologic conditions, as you know, when they compared it independently. That said, when the investigator analyzed the cytokines as a group, you can immediately see that there are distinct expression patterns for each one of the conditions that they were looking at. And certainly visually, you can see that the children with fires has different cytokine expression profiles compared with the other groups, suggesting that maybe cytokine profile is a potential way forward. And Ronnie already mentioned this paper by Aurelie and Larry that was published recently when they took the cytokine profile, serum cytokine profiles plus few additional clinical features in mostly adults with cryptogenic fires, cryptogenic NORSE. They were able to sort of cluster the cryptogenic patient with a cryptogenic NORSE into 4 different clusters, and 3 of which shown here are very distinct away from each other, with the 4th one that sort of kind of falls in between. But more importantly, I think is that each one of the cluster has a cytokine profile that are different, right? So in this case, for instance, the cytokine profile it's more consistent with the dysregulated autoimmune processes. And in this cluster, the profile suggests a hyperactive innate immune response. And here, this cluster basically has like no inflammation that was detected. Now, similar to the earlier paper, all the control subjects that are listed in gray, they're sort of away, they are basically cluster outside of the cryptogenic virus group. And to sort of view the same data in the different ways, the ones that on the red circles are the cryptogenic virus group. Now, the other control, what's actually interesting about the other control group is based on their cytokine profile and the clinical features, they also seem to cluster among themselves. Once again, suggesting that maybe the serum cytokine profile and plus some clinical feature is a way to sort of move forward. Now, while this is actually kind of interesting, but as we all know, measuring cytokine levels, unless you're at Yale or Paris or Great Ormond Street, the turnaround time it's not necessarily available in any institutions, and certainly the turnaround time is long. So it may, as of right now, it may have sort of limited clinical practice until we can sort of make this test a little bit more available with faster turnaround times. So, we, in collaboration with Aurelie and Larry, started sort of exploring the possibility of substituting serum cytokines with sort of more routine laboratory tests that are commonly available in any hospital. And in this case, we decided to use CBCs, right? Because as you know, CBCs are usually one of the tests that we commonly use as a surrogate for systemic inflammations. And so we developed a total of 6 decision tree prediction models based solely on the component of CBCs, 3 for children and 3 for adults, and 1 for each one of the treatment periods. So 1 is before any of the immunotherapies or no immunotherapies, and then first line and second line. And I'm actually just showing one of the decision tree from children to give you a flavor about what are the components and how the flow diagram goes. And here is one for the adults. And what using these prediction models, we actually found that the performance of these independent models are actually fairly good across different treatment periods. And so now we basically need to sort of validate this with larger cohort patients, because this is roughly about 30 adults and 30 children. But at least I think this actually sort of suggests that the readily available clinical data may still be useful in terms of patient clustering, may be useful for patient clustering and for outcome predictions. And this one, Ronnie already went over, which is the clinical score that was developed by our Japanese colleagues. And as you can see, and when they reported their initial findings, has a great sensitivity and specificities. When it's applied to a different cohort, the performance was decreased slightly, and which this is actually kind of common for any of the prediction models. So what are the current challenges, some of the challenges and potential solutions? As we sort of mentioned, that NORSE diagnosis as it stands right now is a syndrome, right? That has no etiologic underpinnings. And so in order to find a unified test or test may be difficult, but using sort of multidimensional assessments such as, combining cytokine profiling with some clinical features may be the way forward. And again, the problem with the cytokine right now is mostly about the availability and the timeliness. And so the question will be whether or not we can substitute some of these with sort of routine tests that are commonly available. And the the sort of short-term possibilities really is to continue to refine what we already have, right? So for the cluster analysis, really, there is still, even though the paper actually simplified the cytokine features, but there is still a lot more than one can do. And what actually was not being discussed is for that paper they comprised the time domain into a single entity, right? So it gives you no insight in terms of when those cytokines were measured. Now, for the prediction model that we are developing right now, we're just using CBCs, but there is no really a good reason why we couldn't include other sort of clinical features such as the number of anti-seizure medications and the length of anesthetic coma and what have you. But more importantly, how we translate what we learned to the bedside clinician is whether or not any of these analyses can be sort of put into a web-based application so that the clinicians can plug in the values and have some kind of immediate feedback rather than waiting for us to sort of do the basically all these available tools are basically only available in the clinic, in the research right now.
All right, well, thank you very much. One of the questions was answered in the chat. We have time for perhaps just one question before we move on, if there is another question. All right, I don't see any other questions, so we're going to move on to the next talk by Nicholas Gaspard on the mechanisms of refractory status epilepticus and its treatments. Nicholas?
Yeah, thank you very much, Jim, for the invitation. It's a pleasure to be here today. Hope you can see my slides. Let's just get me that out of the way. All right. So yes, I'm supposed to talk about the mechanisms and treatment of refractory status epilepticus in a bit less than 20 minutes, which is a kind of a challenge. These are my disclosures. None are really relevant. I get funding for doing research on status epilepticus, but that doesn't really apply to this presentation. So we're going to talk about refractory status epilepticus in general, not only NORSE or FIRES, but broadly refractory status epilepticus, which is defined as status that persists despite 2 adequate lines of treatment, including a benzodiazepine. And beyond,
I'm not seeing your slides, Nicholas.
You're not seeing my slide.
No,
apology.
sorry.
So there were, yes, maybe now. Okay.
Perfect.
That's good.
All right. All right. So yeah. So just to restart here, we're going to talk about refractory status epilepticus, not just NORSE or FIRES, but broadly refractory status epilepticus, which is defined as status epilepticus that persists despite 2 adequate lines of treatment, including in benzodiazepine. And beyond refractory status epilepticus, things can get even worse. You can get super refractory status epilepticus, which is refractory status epilepticus that persists despite 24 hours of anesthesia. And if refractory status epilepticus goes on beyond 7 days, it's called prolonged refractory status epilepticus. Refractory status epilepticus is about 10 to 30% of all status episodes. Super refractory is a third of refractory status, and prolonged refractory is hopefully just a small minority. But as you can see, as we go along this severity of status epilepticus, mortality increases and functional outcome, good functional outcome probability kind of decreases. So these are very tough situations, and we need to figure out how best to treat them. And the best way to know how to treat a disease is to understand what causes it, right? So what is the mechanism behind refractoriness? And much of what we know about the mechanism of refractory status epilepticus goes back to many years now, almost 30 years. It's mostly the work from Jaideep Kapoor's group and Claude Wastelin's group, who focused on the trafficking of neurotransmitter receptors, the GABA-A receptor to the GABA neurotransmitter, and the AMPA and NMDA glutamate receptors. And what they showed is just a summary of everything they did. And it's been recently reviewed by Naylor et al. If you want to take a look at this very nice review article. But the message is that if you look at neurons during status epilepticus, and these are slices of hippocampus in vitro, and this is control, and this is status epilepticus, and this is control, and this is status epilepticus. On the left side, you have the GABA A receptor, which is labeled at the same time that synapses are labeled. So synapses are in green, and the GABA receptors are in red. And what you can see is the control condition, they align very well. So the GABA A receptors are at the synapses. They are where they're supposed to be to respond to GABA and get this braking signal to the neurons. Whereas in the status epilepticus condition, they're not aligned. The synapses are still what they're supposed to be in green, but the receptors, the GABA receptors, are internalized. And if you look at the NMDA receptor on the right side, which are the glutamate receptors, it's the opposite story. In the control condition, these are the two top figures. Again, you see the synapses in green and the NMDA receptors in red. They're internalized, they are in the cell. So these neurons are not able to respond too well to glutamate. Where in the status epilepticus condition, these are the two bottom images, they do align. So now the NMDA receptor in the status epilepticus condition are externalized, they're in the membrane, and these neurons are so happy to see glutamate and they respond to it. So that's a figure that kind of summarizes it. In the normal condition, you have lots of GABA receptors and very few NMDA receptors at the membrane, and in status epilepticus conditions, kind of inverted. And that, of course, translates into pharmacological considerations. If you give a benzodiazepine, which is a GABA A agonist, to an animal that has been seizing for a while, it will not work very well. So if you look at this first figure here, what you see is time spent in seizures and how long it took for the last seizure to occur. That's the control condition in status epilepticus. If you give a benzodiazepine, diazepam in this case, very early in the course of status epilepticus, boom, you break it. No more seizure very quickly. If you wait 30 minutes, well, you can start to see that you still have some seizures going on despite the benzodiazepine. And if you wait 60 minutes, it works even less well. So there is a progressive decrease in the sensitivity of the neurons to the benzodiazepine because of this internalization of the GABA A receptor. And for the NMDA receptor and the glutamate, again, it's the opposite story. These are the control condition, and we're 60 minutes into giving the drug into status epilepticus. And what you can see is where the GABA A agonists, the benzodiazepine, don't work after 60 minutes. All these glutamate NMDA receptor antagonists, MK801 and importantly ketamine, at the far right, they do work really well, whereas they don't really work if you give them early. So there is a nice picture that emerges there from this trafficking of receptors and sensitivity to different types of drug. The problem, though, is that this receptor trafficking kind of occurs very, very early. It's within minutes of seizure onset. And actually, it does pertain more to established status epilepticus than really to refractory status epilepticus. Because when you look at the clinical situation in humans, actually, these animal data do not translate really well because actually GABA A agonist and NMDA receptor antagonists work equally well in refractory status epilepticus. So most of what we know of the pathophysiology of refractory status epilepticus doesn't really translate perfectly to the human condition. So going now to the treatment of refractory status epilepticus, these are the AES guidelines for convulsive status epilepticus. For refractory status epilepticus down there, what's recommended is continuous IV sedation with either midazolam, propofol, thiopental, pentobarbital, and the use of EEG monitoring. And I'll mention and I'll talk briefly about the importance of EEG monitoring in those patients in a few minutes. That's another recent review on the treatment of status epilepticus, just to show you that at this transition between refractory, super refractory status, because the three key players I think today are midazolam, propofol, and ketamine. And please also take a look at the doses. I think that's an important message as well. We should not be afraid to use high doses of these drugs if necessary. there's been some controversy in the last few years regarding the safety and the risk and benefits balance in using continuous IV sedation in patients with status epilepticus, with a few studies showing increased mortality and worse outcomes. But if you look carefully at those studies, this difference in outcome, this worsening of outcome, mostly apply to status epilepticus without convulsions and without severe alteration of consciousness. It does not apply really well to refractory status epilepticus. And all these studies mix different kind of anesthetic drugs and many confounders like withdrawal of life sustaining therapies, control of status epilepticus, cause of death were not reported. And actually recently, there was a systematic review that it was published regarding the question of the efficacy and which continuous IV drugs should be used and which EEG target we should go for. And the bottom line, I'm not going through all the data in this review, but the bottom line of the review is that the data that we have at N is really heterogeneous. It's usually low quality retrospective series. So there are very few conclusions that we can actually draw from all these studies regarding the choice of anesthetic drugs and EEG targets. That being said, there are a few things that we kind of agree on. Barbiturates, for instance, thiopental, pentobarbital, they don't work better than midazolam or propofol, but they're definitely associated with more adverse effects and longer need for ventilation and ICU stay. I was mentioning the doses earlier on in the talk. There are a few studies showing that higher doses are actually more efficacious than lower doses and probably as safe, if not safer. And there are even a few studies showing that the earlier you use these anesthetic drugs, the faster, the better you control status epilepticus and the better the outcome might be. So actually, I don't think you should be afraid of using anesthetic drugs in refractory status epilepticus, especially if it's convulsive status epilepticus or post-convulsive, non-convulsive status epilepticus in coma. There might be equipoise in other types of status epilepticus, but we need more studies to sort it out. Definitely midazolam and propofol should be favored over barbiturates, as efficacious, less toxic. And there are still questions on which doses should be used and the duration of exposure. But when you decide to use anesthetic drugs, the question you're going to ask yourself is where am I going? What's my targets? And once I've reached my targets, when do I stop these anesthetic drugs and how do I stop them? Regarding the targets, the choice is usually between suppressing the seizures, going to suppression burst, or full suppression of the EEG. And one thing to keep in mind is that as most seizures in patients that are treated with Syvats for refractory status epilepticus are actually non-convulsive seizures, these targets, they can only be followed if you have continuous EEG monitoring. There are a few studies, of course, low quality, small numbers, suggesting that deeper level of sedation are generally associated with worse outcomes, but then there are confounding factors. Not all anesthetic drugs can lead to suppression bursts or suppression. Barbiturates can easily do so, propofol as well if you use high doses, but it's much more difficult to go to suppression burst or even full suppression with midazolam. So some of the association that we see between level of sedation and outcome might actually be due to different choices in anesthetic drugs. And then sometimes you don't choose to go to a deep level of sedation, but you end up there because you try to suppress the seizures. And the only way to get to seizure suppression is actually going to deep level of sedation. So there's another confounding factor. The more severe the status, the more difficult the seizures are to control. While the deeper level of sedation you reach to, and probably you have to reach to, and probably the worse the outcomes. Once you've reached your targets, you're into seizure suppression, suppression burst. When do you wean, and how do you wean? And we have even fewer data about weaning practices and how they might affect outcome. Experts, and this is Jim's survey of a bit over 10 years ago now. Experts are split between 12, 24, and 48 hours of seizure freedom. and they are not, and we're not sure how fast we should go for the wean. Many experts would recommend going weaning over 24 hours of time. I think one size does not fit all, and you have to adjust your strategy to the patient, tailor it to the individual, and maybe using EEG to identify markers of now is a good time to wean might be the way to go. There are some data out there based on the presence of ID epilepsy from birth, rhythmic periodic discharges, and some EEG connectivity features. It suggests that you can use the EEG to decide that now is a good time to wean because the risk of recurrence of status epilepticus is getting really, really low. But again, very preliminary evidence that needs further work. If that doesn't work, if refractory status epilepticus doesn't break once you've given anesthetic drugs, you're into super refractory status, the risk of going to prolonged refractory status epilepticus. There are many treatment strategies that have been suggested, but the level of evidence is even lower than in refractory status epilepticus. Just to point out a few interesting drugs. Continuous IV ketamine, I think that's something that have been getting traction over the last 10 years. There are many case series out there showing response rates anywhere between 30 to 100%, maybe higher if used earlier in the course of status. It's usually well tolerated, and interestingly, it has some supportive hemodynamic effect. So that can allow to decrease or even wean the patient of the pressors when they have to be put on pressors because of the other anesthetic drugs that are given. In a recent systematic review, although it was not significant, it seemed that using ketamine was associated with slightly better outcomes than not using ketamine in super refractory status epilepticus. So it's increasingly used, and there's actually a trial that's about to start of ketamine as a second line agent in status epilepticus. That's the KeySet trial. Another option that I think is also getting some popularity is continuous IV phenobarbital. There are a few studies still, mostly in children's, showing quite good rates of status control with high doses and very high levels, much higher than what you're used to if you treat patients with chronic epilepsy. And interestingly, under phenobarbital, even at those high doses and high levels, many patients can be weaned from mechanical ventilation while keeping a good anti-seizure effect. That's another interesting drug, I think. If you're dealing with focal status epilepticus, there are a few data now suggesting that the use of transcranial direct current stimulation, TDCS, might actually be useful in reducing seizure burden. Of course, that's only a few studies in a very small number of patients, but I think that's really promising. The good thing about TDCS is that it has very few side effects, especially compared to all the anti-seizure medication and anesthetic drugs that we use in those patients. That might be a nice additional add-on therapy in those patients in addition to anti-seizure medications and anesthesia. If we want to think outside of the box, outside of this hypothesis of the trafficking of neurotransmitter receptors, there are many animal studies that I don't have time to go into today, but I just want to mention a few other mechanisms that might be at play in refractory status epilepticus that might translate into therapeutic options. First of all, overexpression of the P-glycoprotein, the multi-drug transporters at the blood-brain barrier that lead to active excretion of anti-seizure medications. There are drugs that can block the P-glycoprotein, so maybe that's an option to increase the level of anti-seizure medication in the brain in those patients. Other mechanisms that have been studied mostly in animal, a few of them in human, the GABA biosynthesis pathway, which highly depend on B6 vitamin, pyridoxine. There is evidence from human studies, that patients with refractory status epilepticus tend to have very low level of pyridoxine in the serum, so they might be lacking the vitamin they need to synthesize GABA. So maybe adding pyridoxine, supplementing those patients with pyridoxine might be useful. there's this interesting phenomenon about the transmembrane equilibrium of chloride ions and the KCC2 transporters. That's a phenomenon that's well known in neonates. That the overexpression of this transporter actually leads to chloride becoming excitatory and not inhibitory. Similar things might be happening during refractory status epilepticus, and targeting the KCC2 transporter with, for instance, drug like bumetanide might actually reverse the equilibrium and increase the action of GABA and chloride. Then there are tons of studies on neuroinflammation, interleukin-8, interleukin-1 beta, P2X7 receptors. Drugs that work on these pathways can actually decrease the severity of status epilepticus. And then there are lots of data also on mitochondrial dysfunction and the blood-brain barrier. All of that is nicely reviewed by Matthew Walker a few years ago. So to summarize, when it goes to treatment of refractory status epilepticus, I think continuous IV anesthetic drugs are still the way to go, especially for generalized convulsive and non-convulsive status in coma, with an attempt to minimize exposure, shorter duration, maybe higher doses, but shorter duration to minimize toxicity, certainly guided by EEG, and try to wean the patient as fast and as soon as possible. Maybe we should use ketamine earlier on, back to the idea that the trafficking of the receptors might actually occur very early in the course of status epilepticus. In super refractory and prolonged refractory status epilepticus, of course, we can use other more anesthetic drugs, but we need also to think outside of the box. Think about immunity, inflammation, especially when we know that it's autoimmunity or autoinflammation driven, like in cryptogenic NORSE or autoimmune encephalitis. But then there are other mechanistic approaches that we need to further study in animals and in humans to try to find better ways, less toxic ways to control refractory status epilepticus. And with that, I'm done. I thank you very much. And if you have time, I'm happy to take questions.
All right. Thank you very much, Nicholas. We have one question in the chat. And the question is, given the pathophysiology, they wonder what your thoughts are about using a GABA drug and ketamine currently from the beginning and titrating them together.
Yeah, that's an interesting thought, especially, again, given the animal data, all those things happen at the same time. Why are we waiting for a GABA agonist to fail to try ketamine? So definitely that's something that can be done. I think there is data from what's his name? There is data out there on combining propofol and ketamine, and actually you can reach intermediate levels of both ketamine and propofol that are not toxic and yet are very efficacious. So that's definitely a good hypothesis and a good plan for a trial.
Yeah, I think the Wasterlane group had hypothesized using midazolam, valproate, and ketamine at the beginning to look at the triple receptors.
Correct. Yeah.
All right. Well, thank you very much. We're going to have a break now, and we will start at 15 minutes past the hour. And thank you. We had I'm sorry. I think all the talks actually had some very provocative questions or comments in there, and there were some comments made and for the last talk regarding the difference, if you want to say between, say, fires and just refractory status epilepticus in general. And yes, there have been proposals to use combined therapy for I hate to say regular status epilepticus, but for all cases of status epilepticus and not limiting it to cases with NORSE or fires. So we're going to get back to our lectures, and we're going to start with Kristen Fisher under the promising immunotherapy section, and she's going to concentrate on the use of intrathecal dexamethasone, which she has become one of the proponents and experts of. Kristen?
Sorry, trying to navigate my screen all at one time. So hi, everyone. Thanks so much for asking me to talk. My name is Kristen Fisher. I'm a pediatric neuroimmunologist and part of our neurocritical care team here at Texas Children's Hospital. And I'm going to talk a little bit, as Dr. Riviello mentioned, the use of intrathecal dexamethasone. So just kind of taking a step back from intrathecal dexamethasone, just to quickly review, since we're talking about general immunotherapies, kind of our current immunotherapy recommendations for NORSE and FIRES include early initiation of steroids and IVIG when you have a patient come in and you're concerned for NORSE or FIRES. In certain clinical situations, you're going to want to consider the use of plasmapheresis, such as those that might have a high suspicion for an antibody-mediated disease such as NMDA encephalitis. And then we want to move fast to using more NORSE and FIRES-directed therapies, which includes anakinra tocilizumab, and our current recommendations state using these treatments within the first 7 days of presentation. And then later you might add in the use of rituximab in certain clinical situations. But obviously, even with these things, as we know, that there's even still some challenges with the early initiation of immunotherapy. Kind of looking further down the line, we're not really sure how much this has changed the trajectory of the outcome of the disease, and even sometimes some of these treatments fail. So it's unclear really when, in certain situations, if I should be reaching for anakinra first or tocilizumab first, and one might respond better than another. And really, if there's other newer alternate options for treatment in these situations, and if I should be moving to using some of these alternate therapies rather than using some of the first-line therapies, or if they should be used in combination together. So why don't our treatments work, or why do we have at times treatment failure? I think this is kind of all postulations. We're not really sure at certain times. Is it possible that we're not getting good CNS penetration of medications? Is it possible that the dose that we're using is not adequate? Because we don't really know, because even with anakinra and tocilizumab, there's not clear dosing guidelines that have been shown or proven for NORSE and FIRES, because these drugs weren't necessarily developed for these diseases. They've been essentially repurposed and shown to be beneficial, but might there be an alternate dose that might be better? Do we possibly need to target multiple pathways? We're using very directed therapies with anakinra and tocilizumab, so is it possible we need something more broad, or we're just not getting really true to the underlying pathogenesis of the disease in certain patients? And kind of looking at the pathogenesis, this is just very broad general, as it is really quite complex, and a lot of things that are kind of been historical in postulation, and things that we're getting a little bit more evidence now based on, newer technologies and looking at these patients. But we see that there's inappropriate innate immune system activation, and then there's also some component of some failure of these anti-inflammatory mechanisms as well. And some of this has been seen on recent biopsy studies looking at RNA sequencing of tissue that has showed that we see these increased expression of genes that show inflammasome activation, microglia activation, and then decreased expression of down-regulatory inflammatory genes. The other challenging part of this is that while we've seen some of these things, we don't have a clear unified Mendelian etiology, so no monogenic disease that's kind of unified all these things together, but we have a few cases that have really showed maybe some indication into the pathogenesis of the disease. And these things are really helpful and important because they're really giving clues and indication as to things that might be helpful and beneficial towards our treatment strategies. So now kind of taking a step back, we'll talk a little bit and focus more on intrathecal dexamethasone. So first, I would say just talking about intrathecal medication as this kind of a newer thing that we're using in NORSE and FIRES and a neurologic disease, I would say primary neurologic disease. The use of intrathecal medications actually has some, historical use in other diseases that affect the CNS, which includes leukemia, HLH, lupus, and now more recently has been used in some cases of autoimmune encephalitis in patients that have refractory disease. It's just kind of a newer treatment that's being introduced into primary neurologic disease. Really, the initial report on the use of intrathecal dexamethasone was a case series that came from Dr. Harino, and this was a group of 6 patients. That included 5 acute patients, and 1 was a chronic patient with fires. IT dexamethasone was added after patients had received IV steroids or IVIG and failed treatment. There's a broad range of the timing of initiation of dexamethasone, but overall, what we saw is that patients were able to be weaned from anesthetic infusions around 5 days from the initiation of intrathecal steroids. And I would say, although the numbers are small in this group, something that was noted and something to take away and potentially leading towards our next steps is that those that had a later introduction of the use of intrathecal dexamethasone did have an increased ICU length of stay. And then going after this, now we've had further individual small case reports that have used intrathecal treatments in the cases of fires and NORSE, antibody-mediated NORSE as well, all which are showing a decreased or help with ability of weaning infusions. That was like a perceived response from the providers caring for the patients, although it's important to note that a lot of these patients still had significant neurologic deficits at the time of hospital discharge, but we don't have a lot of information really kind of in terms of the long-term follow-up of these patients to really know. And then more recently, there has been a larger case series that came from the NORSE biorepository group that had 12 patients with NORSE, including those with fires that were treated with intrathecal dexamethasone, with a median time to treatment that was similar to the initial group series that was reported. And I think it's notable that there was perceived benefit in 10 of the 12 patients, so that while we have this bias that there are some patients that respond, there are some patients that we feel like maybe it doesn't provide benefit, and still some information to learn a little bit about there. And I think also important that these patients still had some degree of disability at the time of discharge. And then even further then to add on to that, there was a case series of 2 patients that came from our hospital here that were patients with fires who were refractory to kind of what we would consider our first-line treatments, including anakinra and tocilizumab, that were unable to wean from anesthetic infusions. Based on the difficulty with weaning, these patients were given intrathecal dexamethasone in addition to their ongoing systemic immunotherapy, because we felt as though there was still maybe some benefit from the therapies, but just wasn't getting us to our ultimate goal. And we added on treatment, and importantly, both patients then were further able to wean from their anesthetic infusions, which they were unable to do with their systemic immunotherapy alone. And I think also importantly is that the patients had no infections or other adverse events related to this treatment. So potentially showing that this is a possibility as a next step for treatments or something to consider earlier in the treatment. So I think the next thing is why does intrathecal dexamethasone work in these patients? I think it's hard because we don't really know or understand the exact reason why. Maybe it's because it's more targeted to the central nervous system rather than using a systemic immunotherapy. Maybe our IV steroids were not getting good CNS penetration, but we really don't know. It maybe has a little bit more broad coverage than our other treatments. And so it's kind of smacking down multiple pathways rather than just one specific pathway. And it maybe has a little bit of a stronger anti-inflammatory effect. I think the pros, the positives of using and kind of our use for it is that it is a localized treatment. So in patients that are very sick in the ICU are already worried about them getting infections just related to their hospitalization. This is a very direct treatment, so maybe isn't kind of knocking down their whole systemic immune system. The side effects that have been reported in other cases is generally very transient. And in our patients with NORSE and fires that have been treated, there's been no side effects that have been reported. It has a very short half-life, so it's in the system for a very short amount of time, so not something you're worried about a long-lasting effect. And additionally, it appears to be safe to use in combination with systemic immunotherapies, although the numbers are small. I think the barriers with our use at this point in time is really there is a need for more formalized protocols. We kind of, I think, all use something a little bit different just because there's not something that's standardized, as this is kind of a newer thing that's being used for us. And then also because it's a newer thing, it's maybe a little bit more difficult to implement in your institution. So a lot of times we need to get special agreements or buy-in from the hospital administration, including your pharmacy, to try to help proceed with this treatment. And so it does require a little bit of planning discussion that sometimes is a little bit challenging if you have a patient that suddenly comes in and then you're talking about trying to use these therapies. So I think really importantly for the next steps for using intrathecal dexamethasone or talking about intrathecal dexamethasone in NORSE and FIRES is really based on some of the data that we have is really to consider the use of intrathecal dexamethasone early in the treatment. So rather than saying, oh, I'm going to use it as a rescue therapy when things like anakinra or tocilizumab fail, we've seen that it's safe to use in combination with systemic therapy. So maybe when you're at that day 7 of introducing anakinra or tocilizumab, we reach for that intrathecal dexamethasone at the same time. Maybe it has a more beneficial effect if we're using it earlier than waiting till the end stages of the disease. And importantly, I would say, since we know it's strong to use or safe to use in combination with other treatments based on what we've seen, that I would definitely strongly consider this. I think the other part of this too is that we probably need more as more institutions are starting to use it and reach for it. Just more buy-in from other institutions working together to help establish a clear protocol that we're all using in combination together, to help us better understand really what the dosing protocol should be, which dose, the frequency of dosing, using early versus using as a rescue treatment when all things fail, better understanding the acute response to the treatment and kind of what we're gauging as a response to treatment, and then what the long-term outcome be if it really helps change or affects the trajectory of the disease. But my big message I would say to everybody too is that like we never know when a patient with NORSE or FIRES is going to come in. So if this is a treatment that you've considered using, I would start working with your institution to develop a protocol, because you never know when a patient will come, and it's better to try to help prepare these things sooner now than waiting till they come. And if you ever have any questions or help, we're always willing to work with people. That's all I got.
All right, thank you, Kristen. What we're going to do is Ayol Muskow is going to speak next on the other newer immunotherapies, and we will then have questions at the end. Ayol?
Thank you so much. All right. So it is a real pleasure for me to be here with you guys today. I am a rheumatologist at Texas Children's Hospital, and I'm usually never been as included as this academic and clinical endeavor. And I think that's a testament to the NORSE Institute and the neurology and ICU community in terms of really needing all hands on deck. My disclosure, I've done advisory work for Sobi, though the medication of theirs I will discuss has not been labeled for CNS purposes. So some of my objectives, people have kind of set the screen for me. This is I would say, a thought exercise. I'm not going to redo any of the discussions that we've gotten from Dr. Wickstrom or Farais Moeller or kind of my colleagues at TCH. But hopefully, as a rheumatologist, I'm often in the gray area, and I get to sort of follow that thought experiment to the end in terms of what Dr. Fisher mentioned was repurposing, which is something rheumatologists have to do all the time in terms of novel disorders. And I only put novel here in quotation marks because we're going to talk about medications that are utilized in a whole variety of other conditions. But think about them brought to the NORSE FIRES milieu. Now, I think of the care of a patient with NORSE or FIRES, or the need, as Dr. Wickstrom discussed, bring teams together as sort of an open office concept. And think of your favorite coffee, industrial sort of coffee place. Or if you have had the pleasure of working in an office with cubicles, and you can see there's different people working, and next to you is a microglial expert, and perhaps on the other side there is someone who thinks about clinical research methodology. And I'm really happy to say that I think the community, including families, have come together to try to answer some of these questions. Now, the other part of things is, so that's me on the left there, kind of old-time country rheumatologist. When I get a consult to go to the ICU for a patient with fires or NORSE, this is the image that comes to mind. And I check my Fitbit, and my pulse definitely goes over 110 or so. As I might understand or think I understand how to deal with peripheral immune cells, whether they're monocytes or macrophages or lymphocytes even. I might have a few disorders where we have neuroinflammation. I can probably understand how a peripheral immune response leads to neuroinflammation. But once you throw in astrocytes and microglia and their interaction with infiltrating peripheral cells, my pulse really goes through the roof. And though in no way do I think we understand this as a community, I do think I'll go to this figure a couple of times to discuss some of the medications we perhaps know how to use as rheumatologists that maybe can be utilized for systemic inflammation, and potentially, if there's some bleed through to the intrathecal and CNS compartment, perhaps to be utilized to reduce neuroinflammation. Now, I want to bring to your attention one case report, and I don't know if Dr. Wells and some of our members from the Children's National Team are with us, not so much to describe how to take care of a patient, as we've heard from multiple speakers that almost each case, whether it's a child or an adult, are their own textbook. And it's sort of hard to this is the best image I can get from this paper, but this is a child who is 5-year-old who had quote unquote traditional fires, if there is such a thing, and with a high seizure burden, had IVIG. It seems like they followed consensus guidelines pretty closely, had anakinra, did not have much control of seizures, switched to IL-6 blockade and also B-cell depletion. It's not quite clear why, and I don't think that's particularly important. But then later on there, even though there was some control of the seizures, definitely had features of HLH with hyperferritinemia and biomarkers consistent with an interferon gamma response, and indeed was switched to an interferon gamma blocker, which I'll talk about towards the end of today's talk, and then was maintained with a JAK inhibitor for 12 months. And indeed, at least this one case, this kiddo did fairly well, better than perhaps expected. And again, I'm not using this case as a scaffolding for what we need to do, but perhaps aspirations for the future. In terms of bringing together teams, the nice thing about this paper is you have trainees, you have translational scientists, you have intensivists, rheumatologists, neuroepileptologists, neurocritical care physicians that to come to the table to take care of these patients. And obviously in terms of real-time bench to bedside diagnostics in terms of making clinical decisions. I still struggle, as I think many of us, are we dealing with a immune dysregulatory process that starts the periphery and propagates neuronally, or are we dealing with a seizure disorder that propagates a neuronal inflammatory process that perhaps then has a peripheral component? And I'm not sure we really know, and I'm not sure with this talk, am I going to get us any closer to an answer? But potentially there's some agents that might work on multiple pathways and in multiple clusters of patients. And indeed, the first pathway I discuss is the JAK-STAT. And again, there will not be a quiz later. I think as a rheumatologist, I still struggle to follow the bouncing cytokines. But as I'll show in the next slide, there's a variety of triggers that will propagate a cytosolic signal to a nucleus one in terms of cytokine production in a variety of immune cells. Those are immune cells of the periphery, but also some of the resident immune cells of the CNS, such as the microglia. And indeed, two expressions I've heard from colleagues. You should never leave an ICU without being on a JAK inhibitor. That was definitely the case during the COVID pandemic. Or the other expression, all roads lead to inflammation if you're a JAK-STAT inhibitor. And indeed, as you can tell there's a whole variety of triggers, and I think many of the speakers before me have discussed some of these that may rev up the JAK receptors and the JAK-STAT pathway. There's some selectivity in terms of which agents block which receptor systems. But indeed, if you think of IL-12 or 23, interferon gamma, IL-6, type 1 interferonopathies, as we might see in Carty-Gutierrez, and then some other agents, almost all of these may propagate an inflammatory response, both in the periphery and the CNS. And perhaps an agent that we can go to, and as we think about immune suppression, immune modulation, hopefully we can get past just the salvage therapy, but perhaps with some of the work that many of you have done in this symposium to try to get at early recognition of immune disruption. Now, this is me thinking about the JAK-STAT pathway on a given day, and that's because obviously inappropriate activation of this system may lead to a pro-inflammatory macrophage milieu. That leads to overactivation of a variety of cytokines that many of you have already spoken about this morning. That may lead for macrophages being able to infiltrate an abrogated blood-brain barrier. And the thing that strikes me as really odd and potentially dire is that some of the macrophages, when they enter the CNS compartment, may take on an activated microglia-like cellular response and milieu. Now, unfortunately, the JAK1 system may also activate astrocytes. And as I think many of you have spoken before, seizures in itself may include or lead to an inflammasome IL-1 beta-driven response, and that in itself may lead to JAK-STAT activation. So what do we know about JAK inhibition in AE or NORSE? Not much. So a small case series of adults, one of those had NORSE, and a couple of cases of baricitinib use and shown with fires. This is all as salvage more than 30 years later. The one case I mentioned before, and the second one that's in the literature, utilized after LFTs were abnormal, and both of these agents were maintained for 12 months. These are small molecules, short half-life with some selectivity. It's unclear if the selectivity is important for CNF usage. They're approved in a whole bunch of systemic conditions. If you're in the United States, there's almost never an hour without a JAK inhibitor commercial for almost every indication. The penetration of the CNS is theoretical, actually, with, mostly low, perhaps moderate in baricitinib and ruxolitinib. And the usage, obviously, in Carty-Gutierrez is also with spotty outcomes. There are infection and coagulopathy risks. Now, as I think a few speakers have mentioned, there's also isolated CNS or atypical HLH, and also some case series of secondary hyperferritinemia and fires. As you heard from Dr. Lai, there's also some clusters in some of the studies out there that may have to do with interferon gamma. Now, hopefully a child with isolated CNS, HLH or atypical HLH may have imaging findings of white matter disease with their seizures, and perhaps we can get at early utilization of interferon gamma drugs or HLH types drugs from the get-go. And again, 3 of those 4 interventions for HLH may cross the blood-brain barrier, though obviously a large biologic such as an interferon gamma blocker cannot. And indeed, that's emapalumab. It is approved in multiple parts of the world for primary HLH. Hopefully in the United States, we'll soon get a secondary HLH utilization. It can be done in an outpatient, but also in immensely sick patients in the ICU. There's definitely a sense of viral reactivation. And in many of our countries and institutions, its usage is restricted. And from the figure here, you can tell multiple ways to get at the JAK-STAT system, obviously by blocking interferon gamma, tocilizumab blocking IL-6, anakinra with other mechanisms, and then there's your ruxolitinib or your JAK inhibitor. Finally, though, for my last sort of couple of minutes here, as I look at this figure again and hopefully get my heart rate down, there are multiple places in terms of epileptogenesis and neuroinflammation where IL-17 may be propagated. And this perhaps leads to other medications that can be repurposed from rheumatic disorders, and that's the IL-17 or T helper 17 pathway. As many of you are probably aware, IL-17 is secreted by these T helper cells. It is often stimulated by 6 and 23, And it appears as if the astrocyte is one of the major culprits in producing IL-17. And as I think I've learned, and many of you probably know, so I don't want to mansplain, that astrocytes may activate microglia to the point of propagating a neuroinflammatory response. Now, I think some of the speakers before have tried to talk about the crosstalk between the innate and adaptive or humoral immune system, and potentially this pathway is a linker in terms of an innate immune response becoming adaptive or vice versa. There's some older literature, now 6 years old, of patients with refractory epilepsy, so not just NORSE, and also autoimmune encephalitis, living in a pro-inflammatory IL-17 space. And there's maybe a component of NK cell dysfunction also. And there's some literature of IL-17 being able to differentiate cerebral vasculitis from other patients with strokes. Do we know much about Th17 blockade in CNS disease? There is some preclinical and clinical work in multiple sclerosis. In most countries, there are multiple ways to get at IL-17, its receptor IL-23 that are already approved for skin, joint, and inflammatory conditions. These are infusions or subcutaneous injections. They're large, non-penetrant molecules, though as we all know, I don't think we understand the blood-brain barrier enough to know what to do with CNS penetration, as Dr. Fisher mentioned, and obviously infection risks, infusion reactions, as with most biologics. And for my last slide, I've mostly talked about cryptogenic or autoinflammatory etiologies. I do think once you have a patient who you think has an autoimmune-driven disease that is refractory to care, there are multiple other agents in the wings, whether targeting plasma cells with multiple agents, newer ways to deplete B cells, whether newer CD19 or 20 agents, bispecific antibodies that are taken from the cancer world, or other lupus medications that inhibit B cell propagation. And obviously not just IT-DEX, but other intrathecal interventions. I think there are days and years where the care of children and adults with fires seem like this tunnel, not too far from my workplace. There's no light at the end of the tunnel, but I think much of the work from the speakers before me and many of you that are attending the symposium, I do think there's a little bit of light at the end of the tunnel as we understand some of the biology and hopefully can get to repurposed drugs. And I think hopefully that leads to the continuation of open office concepts, bringing teams together. We operationalize some of the readouts of relevant biomarkers at the bedside, and hopefully some of that data can be synchronized and actually transformed into trials or comparative effectiveness studies. And I appreciate everybody's time today, and I look forward to hearing the rest of the speakers. Thank you so much.
Yes, thank you very much, Ayol. We've had some back and forth in the chat with some questions, but then I would also ask Kristen if she could comment for everyone on the use of IT-DEX perhaps chronically, and whether you've used it for a second trial or for a second course.
Yeah, sorry, we are having back and forth in the chat. I will say that it has come up in there was one patient that we treated in the acute course that got readmitted to an outside hospital, and it came up the question of redosing, and Chris and I have talked about using outpatient, and I think that it's hard because there is obviously not a lot of evidence or data that says one way or another. I think that we've had patients where if they have readmission with recurrence of refractory status epilepticus, that I think it's worth considering, especially if there was a response in the initial treatment. But I think it's just because there's not a lot of data, it's hard to know. And so I think having an open conversation with the family that maybe we've reached for a lot of things that haven't been successful. And you're kind of almost in this reaching for straws thing, trying to find something that might, throw something at the wall and see if it sticks. And there's not a lot of evidence for it, but if it's a low risk thing that's worth trying, I think it's worth considering in certain patients. So that's where I would say readmission for, recurrent refractory status, difficult to control seizures in the outpatient setting that have been refractory to a lot of medications. And if you're seeing like frequent recurrent admissions or something like that due to recurrence of status epilepticus. And then in patients where if you still see there's evidence of ongoing inflammation, while we're not frequently like retapping patients in the outpatient setting to say like, oh, there's evidence of ongoing neuroinflammation, but if you're still seeing some evidence of systemic immune dysregulation, then you might suspect that maybe there is something neuroinflammatory going on as well, and it's worth considering.
All right, thank you. I see one hand up. We'll leave that for the question time at the end. So next we're moving on to perhaps one of the most important aspects of what we should do early would be the prognosis and the communication of NORSE. And we're going to have Krista S. Bach and Lakshmi Demerla speak on that. So thank you very much.
Hi, I'm Lakshmi, parent of Nishant Kalavakalanu, taking us back to about 2018 Labor Day weekend. We had gone to Colorado Springs to celebrate our son's achievements at the U.S. Air Force Academy. We looked up and saw a glider soaring across the sky, and it is something that he was doing at that time. And he would soon be training the next class of cadets. Our hearts swelled with pride. 2 days later, after a weekend of joy and celebration, he said he was feeling tired and wanted to take a nap. He woke up again 12 weeks later. 7.5 years later, we still live in the aftermath of NORSE fires. We didn't know what the prognosis was then. Nishant was struck with this as a 19-year-old on active duty and now fights as a retired veteran. Even now, there are lonely, frustrating, disorienting days for him and for us. The loss of a loved one or the life that we once knew is the common thread that binds many of us here together. Whether it's the grief of what we were before or the person we have become after, NORSE reshapes not only the patient, but the entire family. We were staying across from the ER, and so we got him into the observation within minutes. Every test, lumbar puncture included, came back negative, and yet he was seizing almost hourly. Despite the seizures, because his vitals were stable, he could not be admitted into the ICU. So we moved to a second hospital. And in the second hospital, in the ICU, his seizures escalated and he was put into an induced coma. Our ER doctor friend told us, think of it as rebooting a computer. A few days later, things should normalize. But twice they tried to reduce sedation and twice he seized violently. IVIG and plasmapheresis were attempted. Eventually, he was airlifted to a third hospital. ICUs aren't designed for months of care. Treatment was supposed to be seamless in spite of weekly physician rotations, but that was not the reality. Each week brought a new neurologist with a different treatment plan. One raised his phenobarbital, another thought it was too much and lowered it. We spent almost 24/7 watching our son, keeping track of the changes in medication and symptoms, listening to the patient's families of utmost importance, and planning the treatment and changes with the family might help the neurologists also. One Sunday night, they halted the coma medication based on a phenobarb level of 14. 17 hours of seizures followed. We escalated our concern to the director of the ICU, who brought in a NORSE specialist, a pediatric neurologist, to consult on the case. He became the single consistent voice and started anakinra, raising it to 6 doses a day. Slowly there was progress. Just as hope returned, Nishant's gut shut down. 90% of his small intestine died due to lack of oxygen. The Air Force was told to prepare for the worst, but the ICU doctors, residents, and surgeons didn't give up. Against all odds, they found a cocktail of medications that brought him back. Nishant would not be here if it was not for the care of the ICU nurses, the assistants, the therapists, so many people that took care. We later heard that the EEG techs were cheering the day he tried to rip off his EEG leads. It was a sign that he was waking up. Rehab meant relearning to walk, talk, and think while tapering a high dose of phenobarbital, which was more than even blood tests could measure. We joked about betting on the daily drug levels. Sometimes humor is the only anesthesia that a family can get. Today, Nishant attempts to live independently, managing long-term effects of short bowel syndrome, cognitive hurdles, side effects of medication, and frequent seizures. He takes 1 or 2 classes at UT Austin. That in itself is a miracle. 7 years later, his prognosis is still unknown. If I can leave you with anything, it's this. NORSE fires is brutal, mysterious, and under-researched. No family should have to beg for consistent care. No patient should be passed from one shifting protocol to another. We need research, we need awareness, and we need compassion that lasts longer than a hospital rotation. Thank you for listening.
Thank you.
Thank you, Lakshmi, for sharing your experience, and Nishant as well. I don't know if he's able to be on, but I also appreciate him allowing his experience to be shared. I think you really highlight that despite the unknowns in NORSE, it's really important to consider how we are communicating around this diagnosis with patients and families. And so I really want to thank Dr. Riviello for allowing me to talk about communication in NORSE for a few minutes during the symposium, and hopefully kind of bring some ideas of what we can do to improve in this area. So let me just share my screen. And so I didn't introduce myself to start, but my name is Krista Eschbach. I am an epileptologist at the University of Colorado and Children's Hospital, Colorado. So I have no significant financial disclosures. I will mention that some of the research we'll discuss that I've completed was funded by the friends and family of Finn Musseter, and so really important to thank them for their contributions. In the next few minutes, what I'll hope to cover is to follow up a little bit on what Lakshmi had shared as well, but list some of the unique features of NORSE that influence the approach to communication and that are important to consider, to describe opportunities for improved communication, and then also identify strategies to improve communications with patients, families, and between teams. So some of the challenges related to communication around NORSE we heard about just a little bit briefly, but some of it surrounds the knowledge about NORSE and the rarity of the condition, including poor understanding of the etiology, range of clinical outcomes, and unknowns regarding optimal treatment and expected individual outcomes when you're speaking with an individual patient or family. However, there are also factors kind of independent of our current level of knowledge or experience with NORSE, such as the length of ICU admission and hospitalization, that are really important to consider when we're discussing and supporting patients and families, as well as that this is a diagnosis that occurs in a previously healthy individual, and that there is also multiple services involved, both acutely when in the hospital and also long-term, even after patients are discharged from the hospital, and kind of how to consider all these different factors are really important as we're thinking about communication. There's some data available when we look at communication trends overall related to NORSE. So this data here that we'll go over is from the NORSE Family Registry, which is data that's entered by patients, families, or could be a surrogate decision maker or healthcare provider if they're authorized. And we will discuss this data from the registry more tomorrow during one of our breakout sessions. But this registry opened in December of 2019, and this data was published in 2024. And so patients could enter data if they had diagnosis before 2019, even though the registry didn't open until then. And so what we see here is that about 3/4 of patients received the NORSE FIRES diagnosis during the acute hospitalization when looking at the registry as a whole, and this was in the first 103 patients that were entered in the registry. But there's some improvement in that communication of diagnosis over time. So when we look before 2018 and after 2018, that rate before 2018 was 60%, and it goes up to 85% of patients being informed of the NORSE FIRES diagnosis. And what happened in 2018 and why we were looking at that cut point too was that's when the consensus definitions came out about NORSE and FIRES. And so we do see an increase in patients receiving this diagnosis acutely during that time. About a little over 2/3 of patients reported receiving prognostic information during the initial admission. And when we looked at a rating of that prognostic information, it was rated at about a 6.6, 0 being no information, 10 being complete information. And then when we look at overall satisfaction with communication with the healthcare team, again, rated on a scale of 0 to 10, it was rated at a 7.2. We do see that there is, from the registry, improvement in satisfaction with communication over time. So it is something that, again, is getting better. And that also, the satisfaction with communication also correlated with the amount of prognostic information provided. So highlighting that it, is important to make sure that we are discussing prognosis even amongst the limitations and unknowns related to the diagnosis. And another thing that was looked at as part of this registry is the involvement of palliative care. And so palliative care is actually was not reported to not be involved in approximately half of the NORSE cases. Next, I want to highlight some additional kind of quotes from patients and families when I'd interviewed them about their experience around the time of diagnosis and afterwards. And I think, again, before we go into looking about solutions related to communication, it's just really important to listen to patients and families and decision makers about, what they are hearing and what they need from their healthcare team. And so I'll read through these quotes just to allow us all to take them in. So one thing we relied on the doctors a lot to tell us was what she would be like, and almost everything they said is so wrong. I don't know if it would have been better for them to be right or just not tell us at all. There were some doctors who were so vague that was frustrating at the time. Another one that I think is important to consider, especially when we are looking at outcomes and how oftentimes we don't have as much information about long-term outcomes. But this person highlighted, if they don't know what a long-term outcome could look like, the doctors might give up too soon. I would say that knowing how seriously ill he was, that we feel in some way very, very fortunate. Our son continues to be a source of great joy. I think they need to see how the survivors are doing. So again, I think that's one of the, highlights, one of the things that can be a benefit of this conference and that the NORSE Institute's really tried to do is to help connect physicians and researchers with patients and families. And to help give some of that perspective as well. Again, also with the idea of collecting more long-term outcomes from different projects that are ongoing. Another quote is, I think empathy, explaining the roadmap, telling them that this is a long journey ahead and this is where we are. So another important thing to consider. The most important thing a doctor has to remember is that their specialty is just one part of this person, that there's a big picture that is like what you prescribe for his brain is going to affect all the other parts of his functioning and his family and everything else. So again, this just highlights all the different specialties that can be involved and how we need to consider that. All right, so this is data from another paper that was done by Dr. Farias-Muller, who you heard from earlier today, looking at social media usage and patients with FIRES and some of their perspectives from comments in a survey that was done. And this was recommendations from FIRES families. And I think what I wanted to highlight here is they made comments about recommendations for families and also for the medical team. And the themes that came out were the importance of support, so spiritual, human, and actually social media has provided some support too, as well as expertise. So the importance of finding experts and then also empowering families to become experts. And then also the benefits of specific medical advice as well. And I think, one of the things when they mention, expertise is that even for clinicians and their providers, if they have limited experience with NORSE, the idea of reaching out to others, collaborating with others, not being afraid to ask others when you have a patient with a rare condition that maybe you have not seen as much or been less familiar with like NORSE and fires. So when we think about some of these challenges with communication specific to NORSE and fires and some of the unique aspects to consider, one of the things as I was thinking about, what can we do better from a communication standpoint? I really wanted to pull some lessons from the neonatal ICU. And this is data and a framework that was put together by Monica Lemon when she was looking at, she conducted interviews with parents of infants who are in the neonatal ICU and how communication related to prognosis and diagnosis is relayed at that time. And she mentions this aligned framework where thinking about the approach and considering the appropriate team and venue when you're communicating, ensuring team consensus prior to having important discussions about prognosis and diagnosis with patients and families. The importance of also learning from patients and families, so eliciting their communication preferences, assessing their baseline understanding and goals as well is a really important piece of communication. And then there is also the aspect of informing that you want to do next. You want to be transparent and thorough, acknowledge uncertainty, which is something, as we've heard today, there can certainly be a lot of uncertainty with NORSE and fires, whether it be related to treatment and or prognosis. And or the underlying etiology, as we also heard about. We want to provide balanced information, promote understanding, and importantly also discuss effects on day-to-day life. So when we're thinking about prognosis, also important to give support, so communicate with empathy, offer support in real time, and then also the importance of connecting with peers and connecting with resources. And so I think, again, the NORSE Institute has really embraced this being a support and resource for patients and families, and so providing this to our patients and families when we're giving this diagnosis. And then some additional opportunities for improvement and recommendations that are specific to NORSE. So here's the two publications that I'll review in the last few slides. So when we're thinking about communications with families and surrogate decision makers in the ICU, I kind of broke these recommendations down into a few steps. That's kind of similar to the aligned framework. So first, you want to aggregate information from different consulting teams and establish a unified plan. And then when you're thinking about the idea of actually having a family meeting, who should be there, when should it happen? So you want to arrange family meetings with interdisciplinary teams, palliative care, and the family, your decision makers. You often will need frequent conferences to update the family and decision makers as the patient's condition and family perceptions evolve. And importantly, when we are having a family meeting or conference, it needs to be in a quiet, private room where everyone can be seated and unrushed for the discussion. So it shouldn't be something where families are not prepared that this discussion is going to occur and kind of be, bombarded with this information. Importantly, in terms of the learning from patients and families that came up in the aligned framework as well, you need to determine the family's understanding of the patient's condition and also evaluate for their perspective on the patient's goals and values for care, and including this in a values history and in goals of care discussions. Important to state the term, new onset refractory status epilepticus, to name the illness, acknowledging uncertainty, and using terminology that patients and families can understand. The other idea that's important too is using the idea of best case and worst case scenarios, especially when there is a range of outcomes and prognostic uncertainty. And importantly, do not assume another consulting team has already informed the family. Again, the idea is that these are multidisciplinary discussions as well, but it is, we can't assume that information has been relayed. Discuss treatment plans and alternatives in the context of the patient's objectives and values, and then discussing probable illness trajectory and most likely outcomes, so families and surrogates know what to expect post-discharge. And then when we look at another important piece is communication between healthcare teams and allied health teams. And so one thing that came up is identifying a leader. So the person who's kind of considered the overall responsible physician. And because the NORSE, the hospitalization acutely can be so long, and even in the ICU, the idea and the recommendation is really to have someone that kind of leads the teams and can iterate recommendations for multiple consulting services and with the family and the decision makers. Ideally, this leader should remain the same person, or at most two throughout the hospitalization. I know that, depending on institutions, this may not be always, possible, and there's lots of people involved in the care. But again, this is one of the recommendations from some of the data that's some of the publications that are out there. Also incorporating a palliative approach to care early in the disease trajectory, using communication, shared decision-making, and NORSE is complex and outcomes can be poor. And so really want to make sure that we are focusing on assessing, goals of care and having that additional support from a palliative care standpoint as well. Another layer of support for patients and families. And then consider interdisciplinary rounds for NORSE cases and provide opportunities for continuing medical education to improve the knowledge and understanding of healthcare team members unfamiliar with NORSE. So again, this isn't just a benefit to patients and families, it's also a benefit to other team members to learn about the diagnosis. And then lastly, communication across institutions and to the public. And so again, I really wanted to highlight all the efforts that the NORSE Institute's done with venues like today and the family conference tomorrow, but sharing information about NORSE and fires, raising awareness, inviting experts to do grand rounds on the topic of NORSE. Again, really just getting increased awareness and knowledge about NORSE and fires out there. So next steps, I'll just highlight a little bit briefly what we're doing to help improve communication as well. So ongoing collaboration with patients, families, and caregivers through the NORSE Institute Patient Family Advisory Board. We are also doing a survey of family members and caregivers regarding communication during the acute ICU admission, so to get more detailed data compared to what's in the family registry, and then ongoing efforts to improve communication regarding diagnosis and prognosis. I also want to highlight, we focused a lot on the acute communication. We've talked about early diagnosis, early treatment, acknowledging though the importance of communication after hospital discharge as well, and even through the different phases of care. So when patients go out of the ICU and they go to rehab as well. And then here is a link for the communication survey that we have up and running. This is for patients and families, which I know we have some on today as well, but also if you, for any of the providers, if you want to take this link or do the QR code, and you can also give it to your patients and families to fill out a survey about the communication that they received in the acute ICU course. Great.
All right, well, thank you, Krista and Lakshmi, for that part of the talk, and especially for Lakshmi for very eloquently letting us know what the effects of this are on the families. We do have times for some questions if people have questions. But I think those recommendations that Krista made at the end are very important, right? I mean, someone has to, in a sense, put all the information together, and it can't be just multiple teams who do a week or two at a time. That it would be ideal if there would be somebody that would be able to be sort of the captain of the ship. There's a statement in the chat how important it is for colleagues around the, oops, it just moved, for colleagues around the world to consider bringing their cases to the International Clinical Case Meeting. That is something that Marios and I all have been doing. So just to remind people of that. It can also be very helpful for the families that the family knows that the case has been discussed with some of the experts around the world and bring back information from that discussion to the families. I think that that's very, very important. Any other questions before we move on? Any comments? All right, well, then we'll move on to the biorepository, and this will be with Dr. Hirsch. And, this is something that the NORSE Institute is very proud of having started. And I believe I shouldn't say believe, we are seeing the research coming out of this already that has been, very helpful for our patient management decisions. Larry?
Great, thanks so much. This has been fantastic. I've been taking notes, but I will get my slides up here in a split second. Okay. That look okay?
Yes.
Yes.
Okay, great. So I'll give you a quick update of, we have a multi-center trial in our biorepository that applies to centers anywhere in the world. These are as of March, these numbers. So in our multi-center study, which is through the Critical Care EEG Monitoring Research Consortium, has about 25 centers, all with IRB approved. And we have 87 acute cases of that, and we've started gathering chronic phase and controls as well. In the new open biorepository, where we can take samples from anywhere in the world, we now have, and that's without any particular IRB approval, because we will consent patients directly through Yale. So we have about 55 acute cases, 22 chronic ones, and some controls. So you see we have about 142 patients enrolled in overall in the biorepository. You can see some of these sites that are our top enrollers, and our enrollment numbers are rapidly increasing, which is great. You can see all the different countries that we have gotten samples from. This just shows the escalating numbers of enrollment over the last really 10 years now. It's giving you a little bit data on the patients. We have about 41 in the pediatric age group. If you look at whether or not they qualify as FIRES, meaning having prior febrile illness, it's about 61% of adults and 93% of children. And then seeing how many actually eventually have an etiology found. In the non-FIRES cases, it was 32%. In FIRES cases, it was 9%. And I listed some of the diagnoses found. See, it's really a combination of things. NMDA is the most common, but you see several other things, including some genetic and a few infectious. Yes, some of the FIRES patients have etiologies eventually found as well. We've listed the specific ones there. Outcome are still not good. So 20% did not survive their ICU stay. So it's still a very high number. Looking at outcome in epilepsy, so far about 2/3 have had at least one unprovoked seizure after discharge, which would qualify as epilepsy. They're virtually all, I think all, still on anti-seizure medications. And if you look at, one year follow-up, it's again 67 out of 95 had seizures. As far as outcome, looking at 12 months here, maybe is the best measure. We have about 100 patients who made it there. On the bottom here shows the outcome in those who survive. So there's 67 of those, and I will point out that 15% are actually close to normal, and another 25% may have just mild disability. So there is a large minority of patients that do reasonably well. This just to show you all the biospecimens we have. So there's 125 patients where we have at least some form of biosamples, so serum, CSF, and many others. We have some autopsies, some biopsies. Reminder of all the studies that we automatically do if we get samples, and we will pay for all the shipping. And for cytokine analyses in both CSF and serum, we will get that back to you quickly. If it's in North America, it'll come to us and be run at the Mayo Clinic. And if it's in Europe, it will go straight to Paris, or Lee will help get that done there. So we'll get, within a few days, we'll get you results of the 12 cytokine panel. But for everything else, it's done more slowly and won't help you with your clinical care. It's just research. These are some of the people who have applied for our samples and received them. So we have a steering committee that meets every 3 months or so to decide if there are reasonable requests. And as long as it's a reasonable request and we have the samples and you have the funding to do your research, then we will usually approve it. So that's just some examples. And these are some others. If you want just the data without samples, we offer that as well with a simple application process. That's 2 of the recent ones that have requested data. Recent publications that have come out of the work from the NORSE Institute and the Biobank. The three here in yellow all came out very recently in the past few months. So this is from NYU Claude Steriod's study looking at microbiome. You already heard about the clustering, the inflammatory profiling, and you heard about intrathecal dexamethasone as well. These are just some of the other recent papers. And then there's a few that are in process right now, have been presented as posters, but not yet as full manuscripts, so they'll be coming out soon. Just a reminder of what we have offered at the NORSE Institute. So we will, via email to some of our experts, we will give real-time suggestions for additional diagnoses and treatments. There's more formal monthly case conferences you heard about several times. Those have been fantastic. There's support meetings, there's the family registry. All this, you can find the links at the NORSE Institute website. I mentioned the multi-center trial and the open biorepository. This is how to contact us, norse@yale.edu, if you have a patient you want to enroll. And if you are a researcher and you want to use our samples or our data, let us know that as well, and we'll give you the simple application form that our steering committee will review. Lastly, I want to mention that there is a trial that will be starting in the near future that is funded by the PCORI, which is Patient-Centered Outcomes Research Institute. And excitingly, we now have a name for this. This is called Combat NORSE. It stands for a comparison between anakinra and tocilizumab for NORSE. And I asked ChatGPT to make a logo for this. That's not official yet, but that's the first attempt at that. So this will be, there's some of the information on it, a 33-center, 5-year randomized trial for patients with cryptogenic NORSE at day 7. So taking from Ronnie Wickstrom's paper, that basically at day 7 with cryptogenic, it's recommended to give anakinra and tocilizumab. So this will just make that decision for you, tell you which one to use. So our goal is 310 randomized patients, 129 will also be entered in. If they cannot be randomized, we'll put in an observational arm. It is international. Like we have 8 international centers, including one in Korea, and I believe they're on the call. Let's see, they are, even though I'm pretty sure it's after midnight there. And they will be, this hopefully will be starting in by the end of 2025. Some of the negotiation details are still going on. So we're very excited to get that going. The key players are here. They're all on the call. I think you've probably heard from all of them. And just wanted to thank everybody on our NORSE team. If you contact us, you will hear from either Maggie or Lee or Matthew as our key contact people and key involvement right now at Yale. Krista, you heard from, is also a key collaborator on the PCORI project. And as always, I really want to thank Nora Wong, who's our executive director of the NORSE Institute, has really started all of this and kept us going and motivated, and is one of the co-PIs of the upcoming PCORI study as well. And with that, I'm happy to take questions.
Yes, do we have any questions regarding the biorepository? Because I know there was one question that we need to go back to. I guess just to emphasize again.
Nora just put in some information about, we will cover all the costs, and just contact us at norse@yale.edu. And she put the website. If you just type in NORSE Institute and search engine, that should come up as the first thing.
I think one of the great things about the upcoming trial will be, one could say, finally a protocol that many people agreed on as a treatment protocol, which I think is very, very important as far as trying to standardize, the treatment that we do for the patient. So I think that this will be great trial. I believe that from the first part of the meeting that we had a question. I believe it was Dr. Lai, Yi-Chen Lai had a question that we said we would get to. Yi-Chen.
Hey, thank you. It's actually not a question, but rather a comment. And one of the things that I think what we are learning a lot more about sort of different immunophenotypings, and so this is actually related to Kristen and Al's discussion about sort of immune modulations, at least based on the publications from the recent publication from Larry and RLE. It looks like you have, at least in the adult with cryptogenic fire, it does have sort of different immunophenotypes, right? And so a lot of the stuff that we're basically talking about mainly focusing on sort of dampen inflammatory response, but there is a cluster of their patients that has no active inflammatory signatures, which basically begs the question of whether now on those patients, increasing your immune suppressions is going to get you somewhere. Whereas the one that has similar to autoimmune phenotypes, maybe that, anakinra may not necessarily be the ideal agents in that cohort, and so on and so forth. So I think as we're learning better, hopefully the vision will be, we'll basically understand a little bit better what all these inflammatory signature means, and hopefully it will be a little bit more targeted than as our current approach, which is you apply, immune modulation almost universally across the board. And if it doesn't work, give more, then sometimes that may not necessarily be the approach.
All right, we have some questions popping up in the chat. I do have a question first for Raquel and the biomarkers, and she will be the perfect person to answer this because she presented the data. But Raquel, from the point of view of EEG versus MRI, as far as making the diagnosis as early as possible, can you comment on the comparison between basically your data for EEG, early EEG findings in fires versus the timing of the claustral changes on the MRI?
Yes, thank you for that question. I have to confess I'm going to be biased towards EEG. For various reasons, mainly the fact that I'm an epileptologist by training, but also I think if we think about how these patients present to our centers, normally they won't present. They may present when they're encephalopathic, but more than often they will present with their inaugural seizure. And at very many centers, the first thing that we will do is an EEG, whether it be a short-term EEG or in most centers in the setting of first-time seizure plus ongoing encephalopathy, most likely a continuous EEG. So where the majority of MRI in patients with cryptogenic NORSE are normal in the beginning, usually these patients have who are placed on EEG have some degree of abnormalities. Whether these abnormalities are specific and include the extreme delta brush or include other stigmata, I'm not actually very sure. I think there are more that we are not seeing with the naked eye, and I think that there's more to analyze. And I almost postulate whether this complex neurotransmitter talk, sort of say, and this inflammatory milieu in which this is occurring on the inside can sort of be mapped with continuous EEG. And I love continuous EEG because it's not one snapshot in time. It is a longitudinal way of monitoring. And I think it allows us to study very many aspects of the intracranial environment in many ways.
Yeah, I mean, if you
I
think
vote for EEG.
If you think about neuromonitoring in general, correct, that the importance of bedside technology is important for neuromonitoring, and the continuous nature really of the EEG, I think, gives us more information. Now, the question is we have to know what to do with the information and know how to interpret the information, but I think EEG is better in that regards. And at least personally from your data, we've seen that data early on in the FIRES patients. We've not seen the MRI changes early on. And I think if we want to say early recognition, early treatment, early communication, I think EEG is probably on top of the clinical presentation. I think the EEG gives us the best information.
That's correct. And I think a lot of the MRI changes end up evolving after the patient has been in established status for a longer time. Whereas the EEG changes that we detected in our series a long time ago, actually, they were present before the patient went on a medically induced coma, sometimes in the first 12 hours of the recording.
There were some other questions in the chat about the timing of steroids. At our center, basically, if the herpes testing HSV is negative in the CSF, we'll usually start steroids very early on. Our original protocol, I think, called for doing it by 2 days, but we're generally starting it when the HSV studies come back negative. There's a question that I probably will direct to Kristen regarding if you were going to do either pheresis or IVIG, which one to do first, and pheresis was brought up. But I wondered if you would comment on the zipper technique for some of the immune treatments and what your feeling would be on that for the FIRES or NORSE.
Yeah, I think if you truly suspect FIRES, then there's not been strong evidence that suggests that pheresis is beneficial in patients with FIRES, so probably would skip over pheresis and just go towards other treatments because that might delay getting to things like anakinra or tocilizumab. But if there are certain things in the history that maybe are more suggestive of more of like an antibody-mediated NORSE, then it is recommended to consider pheresis. So if you think you have a strong history that maybe suggests something like NMDA or another antibody-mediated autoimmune encephalitis, such as GAD encephalitis, then pheresis is beneficial. I think it's hard because there's not necessarily like hard evidence that says whether you should do IVIG prior to or after a plasmapheresis. I think there's a lot of people that say that like your plasmapheresis is essentially going to pull out the IVIG. So there's not like a great reason to say if you're planning on doing plasmapheresis to do IVIG first, because maybe you're just like kind of washing away or taking away anything that you put in. There's in certain conditions that are antibody mediated, like antibody mediated transplant rejection and things like that, they do utilize this method of giving IVIG immediately following plasmapheresis, so kind of like in between the sessions. And there are some people that have done that in other like autoimmune neurologic diseases like Guillain-Barré and things like that. I think it's hard because there's still not a lot of evidence. So maybe I would consider that in patients that have based on like its use in like antibody mediated rejection, then maybe if you think you have an antibody mediated disease, it's worth considering. But again, the data out there is very limited at this point. So I would say if you're considering pheresis first, then IVIG after, and you might consider doing this kind of alternating zipper method, but I think still there's a lot to be learned about that.
All right, thank you. Are there other questions? Suki?
Hi, I have a question for immunomodulation and neuromodulation for EL muscle. I appreciated your talk very much. You talked about JAK-STAT signaling pathway, the cytokine storms, and I was looking at patient with refractory epilepsy who underwent surgery. What we have noticed when we did of profiling was that the seizure frequency was inversely correlated with regulatory T cell. And so my interest in regulatory T cell was quite heightened by it. And recently, using the animal model of NORSE, what we have noticed was that there is a response by a extracellular vesicle that actually increases regulatory T cell, which then suppress the seizures and neuroinflammation. And so my question for you, Yale, is that can we go even higher up to these different pathways? And if we were thinking enhancing regulatory T cell, is there a way, do we have already established therapy to enhance regulatory T cell?
I think people, I'm going to start by saying that question is probably above my pay grade, at least for now, though maybe someone can invite me to have a sabbatical to actually understand microglia and the CNS neuroinflammatory milieu. I think mTOR inhibitors may upregulate T regulatory cells. If I'm not mistaken, on that lovely cartoon from the sort of neuroinflammation epileptogenesis review. I mean, there are some places where I think the mTOR system is brought into effect in neuroinflammation. Some people do talk about the fact that tocilizumab and other IL-6 blockers can also upregulate T regulatory cells, but I'm not sure I have a great answer for that. And I think the more research people are doing on, single cell sequencing, whether that's in tissue or in the CSF, if there's enough cells, can maybe help us understand that questions. And it's probably not, there probably still are clustering, and it's probably not the same for every patient, whether it's differences in children or adults. And probably it depends on when the samples are obtained and if that's earlier or prior to therapy. I think none of us really discussed the challenges of biorepositories or biosamples if some of the samples are obtained after therapy. So I don't have and I unfortunately, as always, your questions are immensely compelling, and I'm not sure my answers are anywhere close to as compelling as they need to be.
All right, thank you. I see Dr. Hirsch has his hand up. We have perhaps the time for one more question. Although I might throw in Larry first and say that I like the diagram, but I wonder if the boxing gloves should be holding syringes of something like ketamine.
Oh boy. And we'll see if ChatGPT can handle that.
Okay.
I'll work on it. I had two quick points. One about the terminology of the delta brush. So Raquel's paper showed that isolated delta brushes were common in the virus patients, but the pattern that's very suggestive and really fairly specific for NMDA is the extreme delta brush, which has to be continuing or abundant delta brushes, since it's almost the entire record is covered by them. So that's a little different than just seeing sporadic ones. Then the other point related to Sunte Lee's question about whether IT steroids are allowed in the PCORI trial. The answer is yes to everything. Everything is allowed as long as you haven't had anakinra or tocilizumab by day 7. Everything else we will just keep careful track of and follow it. So we'll still get some data on what other treatments might have been useful or not, given the large sample size.
All right, well, thank you. And I want to thank all the speakers that put a lot of time in for their talks today. And I want to thank the people that attended the conference. And I hope that our concept of early came across as being something very important. So again, thank you all very much.